Hello everyone. Today's class is about benzodiazepines. Actually, you would have studied about benzodiazepines in pharmacology, but this class is a very short class regarding benzodiazepines used in anesthesiology and MCQ points regarding that. Nothing more. Okay, so first, I'm not going to do the classification or mechanism of action. I'm just going to describe about the few drugs that has been in anesthesia practice and the MCQ points regarding that. So midazolam. Midazolam is one of the most commonly used benzodiazepines in the current anesthesia practice, and it also acts on the GABA A receptor. Like all induction agents, it also acts on the GABA A receptor, and it is an imidazoline benzodiazepine derivative. It is an imidazole derivative. Like etomidate, it is an imidazole derivative, and it shows a characteristic pH dependent solubility, meaning so it contains imidazoline ring. So the ring opens at pH less than 4, and if the ring is open, the drug is water soluble. The drug and if the ring is open at pH less than pH of 4, the drug becomes water soluble, meaning our normal body pH is 7 to 7.35 to 7.45. So in acidic pH it is water soluble, in alkaline pH it is fat soluble. So the ring becomes, so in outside in the container it will be like a clear liquid that is water soluble. But once you inject into the body, when the pH becomes more than 4, it becomes highly lipid soluble. So it rapidly crosses the blood-brain barrier and it acts on the brain. So that is how it produces it. It is very easily crosses the blood-brain barrier, and it is 96% protein bound. Like your bupivacaine, your thiopentone, ketamine, it is highly protein bound, and it is metabolized by liver and cleared by kidney. So most of the anesthetic drugs are metabolized by liver and cleared by kidney, and it is one of the drugs which is most rapidly cleared among all benzodiazepines. This statement used to be correct before 2020 June, because by 2020 June, remimazolam, the drug which came after midazolam, which is much better than midazolam, that is what they say. It is approved in United States, not in India. So we haven't got our hands on this drug yet. So that drug is even more short acting than that of midazolam, and it is much more safer than that of midazolam. That's what they say. And the clearance is reduced in elderly and critically ill, meaning in elderly and critically ill patients who are in ICU, the dose should be reduced. So the clearance is reduced, so the duration of action will be longer in elderly and critically ill patients. Normal take-off is 1.5 to 3.5 hours. Now, we know that most of the benzodiazepines will have around 5 actions, that is anxiolysis, sedation, hypnosis, muscle relaxation, and anticonvulsant property. So it is used as an anticonvulsant. Midazolam is one of the most commonly used anticonvulsant. You might have seen in your internship, like when a patient who has suddenly gone into fits, or so you either give midazolam or diazepam. And it is used as a hypnotic. Hypnotic is nothing but sleep inducing agent. Sedative, it calms the patient. Anxiolysis, it reduces the patient's anxiety. Pre-medication, so it is used as one of the best pre-medication drugs in the current practice. And like propofol, it reduces the cerebral blood flow, it reduces the CMRO2, and it produces anterograde amnesia. So the MCQ point here is these 5 actions you should remember, like benzodiazepines, all benzodiazepines. And muscle relaxant action is only there for diazepam, not other agents. And the anterograde amnesia is very important, because once you give the drug, once the drug start acting on the patient, then patient will have amnesia. Like we see it very often in anesthesia practice. So what we'll do is we'll bring in the patient to the OT, or just before bringing the patient to the OT, we'll give a small dose of midazolam, like 1 milligram or 2 milligram. So it will take some 2 to 3 minutes to act. The peak action is around 6 minutes. So these patients, after that peak action, they won't remember anything. After which what happens? Like most of the patients have that anterograde amnesia. Some patients may remember, but it will be very vague and they won't be able to recollect so accurately. So this anterograde amnesia is very important, very common in midazolam. And minimal central muscle relaxant property. The central muscle relaxing property is mainly seen in diazepam, not in other drugs. So here it is very minimal. Opioids and benzodiazepines. Like example, if you give midazolam and fentanyl. Fentanyl is a highly potent opioid. So if you give both these drugs together, there will be a significant fall in BP, as well as there will be if you give in higher doses, it can cause apnea. So apnea means respiratory depression. And in a volume contracted state, this will cause significant fall in BP. Volume contracted state means hypovolemia. So the intravascular blood volume is low, which is called as volume contracted state. So it will cause significant blood BP fall. So here the in this slide, the things you should remember is the 5 properties: anticonvulsant, hypnotic, sedative, anxiolytic, and anxiolytic, and muscle relaxant property. Muscle relaxant property is very minimal for midazolam. So it produces anterograde amnesia, which is a very important MCQ question. And in volume contracted state, if you give both these drugs combined, significant BP fall will be there, and rapid bolus may cause apnea. Now it has a flat dose response curve, meaning it is a highly safe drug. So even if you give a lot of midazolam, like the normal dose is 0.05 milligram to 0.15 milligram. Even if you give a dose of like 5 milligram, 10 milligram at a bolus also, it is safe. It won't cause rapid cardiovascular collapse like propofol or other drugs. It is much more safer than the drug. So the dose response curve is very flat. It is not like it rapidly ascends. It goes very flat. So it is much more safer. Onset of action is more than 1 arm to brain circulation, because it takes around 6 minutes for the peak of action, and the dose is 0.05 milligram to 0.15 milligram per kg IV induction. For pre-medication, 0.5 to 1 milligram IV is enough, which can be repeated. Now coming on to diazepam. So uses are almost similar to midazolam, and also has an additional property of muscle relaxant property. This is very important. Diazepam has muscle relaxant property. This is an MCQ question. To relieve the muscle spasm in spastic conditions like tetanus. So tetanus, we know that one of the most important effects of tetanus is spasticity. So to relieve that, once the patient who has recovered from tetanus, they will still have some spasticity. So to relieve those spasticity, what we can do is we can give a central muscle relaxant like diazepam, which cause both sedation, anxiolysis, as well as muscle relaxation. And in patients with alcohol withdrawal, like normally we use chlordiazepoxide, and in the alpha agonist class, we saw that clonidine and dexmedetomidine can also be given in alcohol withdrawal sympathetic overdrive. Here diazepam can also be given in alcohol withdrawal. It is available in multiple preparations like oral, IV, syrup, and suppositories are available. Because it is a very old drug, we have multiple preparations of this drug. The drug is clear yellow solution. This is one preparation. Another one is white oil and water emulsion. Both contains 5 milligram per ml of drug, and the oily preparation is painful on injection. So both IM as well as IV, it is painful for injection. But this the clear yellow solution is not so painful, and it is 99% protein bound. See, midazolam is 96% protein bound. Diazepam is 99% protein bound. This is another MCQ. And metabolism, it is metabolized by liver, and it is contraindicated in patients with liver failure, because the diazepam will take very long time to get digested. That is the intermediate is desmethyl diazepam. The half-life of this desmethyl diazepam is 100 hours. So it is not so likely used in it can never be used in liver failure patients, and because of this very long ultra half-life in normal patients. Imagine what will happen if you give in a liver failure patient. They will go in for severe respiratory depression. They will go in for sedation, very long-lasting sedation, and can produce spinal mediated analgesia. See, this is very minimal, but still diazepam can cause very low profile analgesic in which acts on the spinal cord level, not in the central level, in the spinal cord level, central in the spinal cord. And co-administrated with cimetidine. Cimetidine is a enzyme inhibitor, so it reduces the clearance of diazepam. Now coming on to lorazepam. So lorazepam, previously diazepam was very commonly used, but nowadays lorazepam has been slowly replacing diazepam in ICU practice and clinical practice. So similar to actions and uses are similar to midazolam and diazepam, but it's a little bit longer acting than that of midazolam, and it is commonly used in ICUs. So dose is 1 to 4 milligram per day, that is if it is oral, and it's 0.025 to 0.05 milligram per kg IV. Normally we use a dose of 1 milligram or 2 milligram in ICU, and IM injection is painful. See, normally IV injection is painful in oily preparation, but here lorazepam IM injection is painful. And there is a mild fall in BP. It is not as much as diazepam or midazolam, and mild respiratory depression is also there. Co-administration with cimetidine does not impact the metabolic clearance of lorazepam. It can be cleared because it can be used even if the metabolism does not impact. Drug is not removed by hemodialysis. So this is important because in this drug is very commonly used in ICU. So sometimes when we give a larger dose, when we give say 4 milligram or 6 milligram, so it cannot be removed by hemodialysis. We have to wait it out. We have to wait for the metabolism to occur and clear the body itself to clear the drug. And metabolism is by liver. Now coming on to remimazolam. So remimazolam is the most newest drug in the benzodiazepines variety, and it is the most ultra short acting imidazole benzodiazepines. So it is approved in previously it was on trials, now it is approved in United States for procedural sedation, total intravenous anesthesia, and as pre-medications and other common uses like benzodiazepines. So similar to midazolam, but pharmacokinetics of remifentanil. So this is an important point because remimazolam is metabolized by plasma esterase. Meaning, if any drug that is metabolized by plasma esterase or any drugs that contains carboxylic acid group can be metabolized by plasma esterase. So those drugs will have very short acting, and short acting drugs are good drugs because the action will be faster and they will come out of anesthesia soon. So all the ultra short acting drugs are good, like remifentanil, esmolol, mivacurium. All these drugs are ultra short acting because they are metabolized by plasma esterase. And so lower doses produces anxiolysis and higher doses produces sedation and hypnosis. So procedural sedation means minor procedure like endoscopy, colonoscopy, bronchoscopy, all these we need the patient to be sedated only for some 5 to 10 minutes. So during that time itself, midazolam or remimazolam will keep the patient sedated, they won't feel anything. Then after that they will wake up. So this is a wonder drug, like according to anesthesia practice. So minimal CVS depression and apnea. There is almost nil to minimal CVS depression and apnea. Onset is within 1 to 3 minutes. Peak action is by 4 minutes and duration is by 10 minutes. See, the maximum duration itself is 10 minutes. For midazolam, it takes around 20 to 30 minutes. Then contact sensitive half-life after 2 hours of infusion is only 7 to 8 minutes. But midazolam, if you give us an infusion, it will take very long time for the patient to come out of midazolam. It will take even hours. And metabolism is by ester hydrolysis, and the metabolite is CNS 7054. I don't think you need to remember this metabolite and all, but good to remember. Then flumazenil. This is a antagonist for benzodiazepines. That is, whenever there is a toxicity of benzodiazepines, you can use flumazenil to reverse the effect of benzodiazepine. So it is a competitive antagonist at the central benzodiazepine receptor. So a clear colorless solution containing 100 microgram per ml of flumazenil. That is there is about the drug. So flumazenil is given IV, that is 100 microgram incremental to a total dose of 1 milligram. So you can give 100 microgram as a single dose, and you can repeat this for 10 times. So up to 1 milligram you can give. So each 100 microgram multiplied by 10 is 1 milligram. So it acts in 30 to 60 seconds and lasts up to 15 to 140 minutes. So because of this very wide duration of action, you might have to repeat the dose. So it may be infused in intravenously at the rate of 100 to 400 micrograms per hour. But the problem here is you need to remember only two things. So once the action is only for 15 minutes to 140 minutes. So once the action of the flumazenil is over, then again midazolam, then again the benzodiazepines will take over the receptors and the patient will again be sedated. So say for example a patient who is taking diazepam for depression or anxiety disorder, then suddenly they take an overdose of diazepam as a suicide attempt and they come to the casualty. What you have to do is you have to administer flumazenil. If you know that they are taken only benzodiazepine, you can administer flumazenil. That is only to see whether the patient is responding to confirm whether the patient has taken benzodiazepines or any other drug. So here the patient will immediately wake up, and then after the effect of the flumazenil is over, they will go back to sleep. Then again you have to wait for the body to clear all those benzodiazepines. Flumazenil can't be given continuously. Sometimes we may keep it as infusion, but usually we use to identify whether the patient has taken benzodiazepines or not. The side effects, I think these side effects you should remember because of these side effects only we are not using flumazenil much. hypertension, dysrhythmias, dizziness, nausea, vomiting, facial flushing, anxiety, and headache has been observed. So the most important is hypertension, dysrhythmias. So cardiac side effects are more. That is why we are not using flumazenil very frequently. Other side effects like dizziness, nausea, vomiting are very common. Now finally, an important point. So resedation after the prior administration of benzodiazepines. So resedation is an important side effect. Much more problematic side effect is convulsions, because this is an antagonist of benzodiazepine. Benzodiazepine, you know, one of the most important effects of benzodiazepine is reduce the anticonvulsant effect. So if you antagonist benzodiazepine, basically the patient will have seizure. Okay, so the convulsions we are very worried about. So flumazenil, it is a competitive antagonist. It is an antidote of benzodiazepine. And the dose given is 100 micrograms to a total dose of 1 milligram. It can be given as an infusion. It can be given as a bolus. 15 to 140 minutes is the duration of action. Cardiac side effects are common. Hypertension, dysrhythmias. We are worried about resedation and anticonvulsant.